Hi there, everyone, and welcome. We are excited about today's webinar. My name is Jeremy, and I'm a representative of EHN Canada. We are a nationwide network of treatment centers for addiction, trauma, and mental health. We have facilities located in Nanaimo, British Columbia, Calgary, Alberta, Toronto and Peterborough, Ontario, Montreal, Quebec, and Annapolis County, Nova Scotia. We offer high-quality inpatient, outpatient, and online treatment programs. For more information, please visit our website at www.ehncanada.com. Just in terms of housekeeping, everyone is on mute and cameras are off for today's webinar, but please feel free to use the Q&A box located at the bottom of your screen to submit questions for our speaker of today's webinar. We will try to get to as many questions as we can at the end of today's session. Today's webinar is in fact being recorded, and we will be sending out a follow-up email next week that will include the link to the video, the slides, and any useful resources mentioned, as well as your CEU certificate. I am located in Toronto. Toronto is located on the traditional territory of several nations, including the Mississauga of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat people. It is covered by Treaty 13 with the Mississauga of the Credit. Dr. Ayaz is located in Calgary, the traditional territories of the Blackfoot Confederacy, Siksika, Kainai, and Piikani, the Tsuut'ina, and the Iai Nakota Nations, the Métis Nation Region 3, and all people who make their homes in the Treaty 7 region of Southern Alberta. If you're new to this work and want to find out whose land you are on or grew up on, please check out native-land.ca. Many more of you may be physically present elsewhere, and I encourage everyone to use the chat function to, where applicable, share whose land you are on. Now to get to today's session, adult ADHD and addiction. Dr. Tim Ayaz is currently a staff at the Clare Home Center for Mental Health and Addictions, Carnet Center Psychosis Day Hospital, EHN Sandstone's private addiction treatment center, and a variety of rural mental health clinics. He teaches often at the medical school and residency level and has been multiple teaching awards for his passion. His administrative roles in education include being the clerkship director at the University of Calgary and the scientific co-chair of the annual Alberta Psychiatric Association Conference in Banff. Dr. Ayaz plays goalie for 2 separate ball hockey leagues, and he lives on an acreage in the country with his wife, who is a rural family doctor, and his 5 young children who love to keep him in a constant state of sleep deprivation. Please help me welcome Dr. Ayaz.
Thank you, Jeremy. Thank you for that introduction. And thank you to everybody joining. I was actually just kind of a little distracted reading the chat bar here. It's great to have people all over from Canada joining us, as well as internationally. So welcome. And I really hope you find this presentation interesting, as well as hopefully something you can walk away with in terms of some new knowledge. So what I'll be talking about is the comorbidity challenge of treating ADHD in adults. I'm an adult psychiatrist who have addictions. Already had a great introduction by Jeremy, so don't really have to add more, just saying that I do work primarily in inpatient residential treatment facilities, so both private with EHN Sandstone located in Alberta, as well as in the public system here in Alberta at the Clare Home Center, but do a fair bit of outpatients and quite a lot of administration and teaching as well. I'm an associate professor at the medical school, and I'm the clerkship director for them, so I kind of help direct what the medical students are kind of doing. So these are my disclosures today. So I do have some relationships with commercial interests in the last couple of years: Allergan, Lundbeck, Otska, Shire / Takeda now, I believe, and Janssen. In essence, just so you're aware too, I have not received any financial payment for this presentation. And if I do recommend anything that is different from Health Canada recommendations, I'll let you know, and I'll kind of let you know the papers or the logic as to why. But generally, a lot of this is all going to be evidence-based today. these are the objectives for today. We're going to go over the definition, prevalence, and impact of ADHD in adults. And just so to let you know too, this isn't something that I actually kind of walked into psychiatry saying, oh, I'm going to become like a person who's really kind of adept at treating patients with ADHD, but I work in so many addiction settings as an addiction psychiatrist that you do then see a lot of patients with ADHD, and it made me a bit of a de facto, subspecialist in this field, because you see the impact of ADHD and how it presents with a fair bit of substance use disorder in later life. We'll talk about kind of recommendations for the selection and monitoring of ADHD pharmacotherapy. And I should also add, I do have a slide on other types of therapies as well besides medication, but primarily it's going to be a medication kind of focus today. We'll talk about the connection between ADHD and substance use, and we'll talk about a really interesting case study actually had in an inpatient residential treatment setting, which kind of walks us through a person who kind of presented with both ADHD and substance use disorder, which may kind of help in terms of kind of having these kind of patients that are going to be very similar to probably what a lot of you will be seeing in your varying different clinical practices here. And then we'll talk about clinical pearls for the management of ADHD, some really kind of interesting factoids and things that, are a little bit kind of higher level in terms of things to kind of consider, questions that come up often by patients. And so it's hopefully going to kind of help as well in terms of how you manage these patients. So let's start first with the neurobiology of ADHD. It's a very complicated illness. In essence, it's a norepinephrine, but primarily dopamine signaling disorder in the brain. It's either an inherent deficiency or potentially, actually, interestingly enough, they have almost too much dopamine and norepinephrine, and that's actually more in the patients with like comorbid tic disorders. But then through a feedback loop, eventually then causes norepinephrine and dopamine to plummet over time. This actually affects a fair bit of your frontal cortex, the kind of the evolved part of our brain responsible for attention and other things. So in the dorsal anterior cingulate cortex part of your brain, that's what affects selective attention, and that's where they have problems with maybe not listening, careless mistakes, etc. Also affects your dorsal prefrontal cortex, where that's more responsible for sustained attention and problem solving. It also affects your prefrontal motor cortex, and that's where you get the hyperactive symptoms of kind of fidgeting and kind of constantly on the go. And then lastly, it affects your orbital frontal cortex, and that's where the impulsivity kind of comes from, where they're kind of talking excessively, blurting things out loud, etc. So it is, in essence, an issue primarily coming down to the dopamine primarily, but some norepinephrine signaling disorder, where all these parts of your frontal cortex are actually then deficient in the end with the dopamine, and hence kind of require the supplementation either through stimulants or other medications. Now, the criteria that we use in psychiatry is from the DSM-5. And I'll go over some of the criteria here, and they'll kind of roll into the prevalence and why international rates sometimes vary. But we'll talk about kind of with a Canadian focus, obviously, here today. So to be diagnosed with ADHD, attention deficit hyperactivity disorder, you have to have a persistent pattern of inattention and or impulsivity / hyperactivity that interferes with functioning or development. And that kind of ties into C and D, where it's present in many settings, as well as it interferes with, especially in older, in adults, so not children, with kind of work functioning, or maybe university students, so still education and social kind of functioning as well. Now, you do have to have, though, that interference with functioning or development, because ADHD in itself isn't necessarily always pathologic for people. In fact, actually, there's a reason why it's lasted, evolutionary wise throughout kind of the millennia in the human race. And part of it is there's a somewhat evolutionary advantage for some people in different settings with ADHD, because they're able to kind of do lots of different things at the same time. They're also a little have kind of a bit more energy. They also would have maybe more risk-seeking behavior, which you think, well, that's pathologic, but not necessarily, because then these are the people that would take kind of these roles in a society that might require a little bit more risk. And so hence they kind of have that niche kind of still, right? So it actually does have to interfere with functioning to actually give a person a diagnosis. So for instance, I met an emergency medicine doctor who has fairly significant ADHD, but it works for this patient because this patient can kind of go, from room to room to room, very fast paced, likes that kind of fast pace in terms of kind of treatment. And so hence actually in that setting, it isn't necessarily pathologic. So it has to interfere with their functioning or development, and it actually has to be present before the age of 12. If it's going to be after the age of 12, you're then more likely to be looking upon like something along the lines of um, category E, another disorder that's probably causing inattention, because inattention in itself, or kind of problems with concentration and memory, are actually an integral part of diagnostic criteria for many psychiatric disorders, and brain injury and neurologic disorders, and actually even fatigue and biological disorders such as sleep apnea. So hence you do actually have to rule out a fair bit of things before you can for sure say that the inattention or hyperactivity symptoms aren't actually due to something else. And actually one good category, or one, actually not good category, one good way or method to actually do that is to make sure that it's been a chronic, not episodic kind of problem that actually has been present even in childhood. And just so you know, too, in terms of Q&A and everything, I will leave some time in terms of at the end for questions that I'm happy to go over, and I think Jeremy will moderate that for us. I should hopefully leave about 10 minutes for there. Inattention. So they have to have at least 5 or more criteria for adolescents 17 and older, so adults too, and have to be present for at least 6 months that are inappropriate for their current level of development. So these are kind of the strict DSM criteria. So failing to give close attention to detail, holding attention to different tasks, not seeming to listen when spoken to directly. These are all things that I'll have on the slides that you can get next week from Jeremy, so I don't have to go over all of them. But I actually find that this is actually a good screening question to catch people and then make you then go through the whole criteria if you kind of are positive for some of these things. So if they kind of often, this is a big one, they lose their wallet, keys, mobile phone. And actually a classic question I ask is, how many phones have you had to buy in the last couple of years? And often for people with ADHD, because most people kind of are very careful with their phones because they're worth so much money now, these smartphones, and they're very careful with them. Patients with ADHD often, I've had to replace it about 2 or 3 times. I've lost my phone, or I've had to get those Apple trackers because I kept losing it before. And so they lose these like smaller things that are very important in a person's life. If they ask them about time management in terms of their work, are they able to meet deadlines? Is that one reason why, the last couple of jobs were terminated? Do you kind of find that at work you're easily sidetracked and kind of can't finish your duties? Do their minds seem elsewhere, and it's very hard for them to kind of focus on anything, including school? And do they overlook or miss details, and hence a lot of kind of their work is inaccurate? These are good screening questions that you could then roll into, if they're affirmative, into some of these questions for inattention. Now, it's either inattention and or hyperactivity or impulsivity. So they could just have this as well. Some examples here are fidgeting often, leaving their seats in situations where you're supposed to be staying there, climbing or running about, and in situations. That's more for kids. To be honest, actually, in children or in adults, it's actually more kind of limited to kind of feeling very restless, often on the go, talking excessively. These are the screening questions, though, that I like to use before, and then that kind of then rolls into this if these are affirmative. Or even in actually your clinic with them, if you're sitting with them, and I usually spend at least an hour or so per patient for an initial assessment, they kind of have a hard time sitting in their seat the whole time, and kind of get up and walk away, or in group therapy settings also. They feel restless. They can't engage in leisure activities quietly. They're unable to sit still for an extended period of time, such as in restaurants or meetings. Actually, a good one I usually like to ask them is like, can you sit through a whole movie, right, on Netflix or in a movie theater? And something that comes up often during your talk with them is they can't really wait for their turn in conversation. They're often kind of cutting people off either in your assessment or in group therapy. Excuse me, caught a frog in my throat. Prevalence in Canada. This is what actually from a wide scale study, population-based study. It's from kind of mid 2000s, but does show that in children it's about 6%. In adults, it's probably around 4%, 4.4%, I believe, in this study. The international rate's a little bit lower. I believe it's about 2.5 to 3%, depending on where you read. And actually in America, it's a little bit higher. And part of that is a bit of a bias in terms of diagnostic bias in both the extremes there, to be honest. In America, it's probably a little bit overly diagnosed, as there's a bit of a fad in psychiatry to diagnose it for a while. But then actually in international places, such as France, is actually probably underdiagnosed, because actually to get a diagnosis of ADHD in France, you actually have to have been hospitalized first, which then sets kind of the bar way too high. So really, kind of the Canadian statistic is probably kind of close to what the true averages probably are. And in adults, it's probably between 3 to 4%. In terms of the timeline of symptoms of ADHD, over the course of time, hyperactivity goes down. In essence, what happened, and impulsivity actually goes down. And in essence, that's because of frontal cortex development as you get older. So can you grow out of ADHD? Possibly for some of those types of symptoms, yes. Unfortunately, though, inattention is actually fairly static. And that can always obviously change upon societal pressures and what you're doing. But that actually symptom doesn't actually change as you get older. Now, the one thing, though, that does increase over time, though, unfortunately, is comorbidities. Comorbidities or other psychiatric disorders actually go up, unfortunately, as time goes on. And that's what we're going to focus on today. 85% of adults with ADHD will actually have one or more comorbid conditions. This talk, however, today is only about one of them primarily, and that's substance-related and addictive disorders. That being said, there's a whole host of a lot of other disorders. In fact, I actually have a separate presentation on all the other ones and comorbidities, but we're going to focus today on substance-related and addiction disorders. So in Canada, they actually did a really interesting study where they actually looked at control groups, and this was in the DSM-4 criteria, so hence they had abuse and dependence, so kind of lighter addiction and heavier addiction in colloquial terms. And patients with ADHD generally have much more addiction issues than patients who do not have ADHD. And they actually, in the control groups here, they actually stratified for kind of similar psychosocial kind of backgrounds and age. So much more addiction within these ADHD groups, and that's for alcohol, cannabis, other drug abuse of different sorts, right? And so hence, unfortunately, addiction is actually a very common comorbidity, to the point where ADHD actually is considered a risk factor for development of substance use disorder. In general, about 25% of patients on the flip side with substance use disorder may have ADHD in some studies. And if you actually look at inpatient residential treatment facilities such as Edgewood Sandstone or Edgewood in Nanaimo, that can be even up to 40%, because these patients have kind of more severe addiction, and patients with ADHD have very high rates, unfortunately, of substance use disorder and more severe variants of it. And so what I'm trying to say is kind of the more severe so first of all, if they have an addiction, you should screen for ADHD for sure. And if they have a severe variant of an addiction, then for sure, please screen for ADHD, because unfortunately, the risk is unfortunately very high for them to have it. So why is there that connection between ADHD and addiction? There's a lot of different theories out there, psychological and neurobiological. First of all, of course, they have a need for rapid feedback if you have ADHD and a desire for immediate reward. And like I had mentioned earlier, they have that high adrenaline risk-seeking behavior type of personality. So hence, patients with ADHD are going to be kind of more prone for substance use because of the inherent symptoms of ADHD. Also, patients with ADHD may use illicit substances to self-medicate their symptoms, help slow them down, especially with stimulants. Also, they have very poor relationships with peers, and hence then, because of their poor self-esteem, and hence maybe using it due to, they may be more under the influence of peer pressure because of that to help kind of foster relationships that they feel are lacking in their lives. Unfortunately, then, with their poor self-judgment and impulsivity associated with ADHD, this is then is conducive then to the subsequent development of substance use disorder once they start. Now, I added this little bit here at the in this slide just to kind of clarify a question I get often by patients. Is cannabis or marijuana good for me to take for ADHD? In fact, actually, it's even marketed so in different kind of trade magazines for cannabis because it says it's calming, facilitates sleep, etc. As it stands right now, we do not recommend using cannabis products for patients with ADHD treatment. And the reason for that is, first of all, if you're not buying it from a distributor, it's often laced with dangerous substances. In fact, there's a local study here in Calgary at SafeWorks that actually showed that there's a fair bit of contamination with methamphetamine, as well as even fentanyl, unfortunately, in cannabis that's sold by black market distributors. If you go to like a store, that won't happen because they're actually regulated a fair bit in terms of contaminants such as that, as well as mold and other things. Cannabis, though, impairs cognition and creates amotivational states. Patients with ADHD already are struggling with cognition and motivation for some of them. And so hence you're really then putting fuel on the fire there. And studies show it will reduce their productivity and functioning, generally in people in the general population, but specifically even for these patients with ADHD. So I get the fact that it helps them sleep for some of them, but that being said, there are safer things to try to assist with their sleep if they're coming to you for treatment than cannabis. And so hence I do not recommend cannabis for treatment. And some people will then kind of counter with, what about CBD oil? Doesn't have THC in it. Well, first of all, the calming effect and the facilitation of sedation is actually more from THC than CBD. So it doesn't even really kind of target usually the symptoms they're kind of going for. And the other thing about that too is even if you buy from a distributor, the CBD oil, it's not regulated in terms of what's actually in that oil. And when they've actually taken these to third-party testing, where it actually says there's no THC in some of them or very low, there's actually still a fair bit of THC in a lot of these oils that they're selling. The only thing that the government really regulates is kind of the contamination with other drugs of abuse, as well as mold and kind of other contaminants like biological contaminants like that. But they actually don't take a look at the percentages of what they're actually marketing in terms of THC percentages and CBD percentages. So you don't really know if you're actually getting pure CBD when you buy CBD oil. And that's something I actually tell a lot of my patients with comorbid bipolar disorder or psychosis, even like not ADHD related, due to the fact that it's actually very dangerous for them to actually have THC of any sort. Now, this causes a bit of a diagnostic conundrum. Substance use disorders may increase the severity of ADHD symptoms. So while they're actively using, the ADHD will often be worse. And then once they're kind of in detox as well during that withdrawal kind of period, that often presents also with problems with attention, behavior, and self-control symptoms that mimic ADHD. So it makes the inherent ADHD worse, or it even presents as ADHD when they may not even have ADHD. So hence, when you're kind of really thinking, I'm not really sure if this person has ADHD or not with their substance use disorder, I would really recommend a referral to a specialist or a healthcare practitioner who can kind of help flesh that out with a complete diagnostic interview and some kind of self-report tests or some other surveys that they can use to kind of help flesh that out a little bit more. there's been a pivotal recent study that was published in 2017 in the American Journal of Psychiatry. And this was actually pivotal in terms of prior to this study, we were actually unsure if the treatment of ADHD changes substance abuse outcomes in people. We always kind of knew inherently in terms of a lot of us working within the field of addiction psychiatry, but there was actually really no great evidence for us to kind of hang our hat on in terms of evidence-based medicine until this study came out and then subsequent trials since. This was a really interesting study where they looked at 3 million healthcare claims from 2005 to 2014 from adolescents and adults who were diagnosed with ADHD. And interestingly enough, treatment with ADHD medications then was associated with a much lower risk of substance-related events in both men and women, and then actually much lower long-term risk of future substance-related events, especially for men, if you kind of started them in adolescence. And the funny thing is, actually, the treatment might not even been a long course of treatment. As long as they've had some sort of treatment at one point, that actually did mitigate kind of any risk of future substance-related events for those patients. So really fascinating study that finally kind of showed, okay, treatment of the ADHD does help them reduce the risk of addiction. So these are some treatment considerations when you have patients with both ADHD and addiction. Now, concurrent treatment is what we recommend the most. So concurrent enhanced or a concurrent disorder treatment, either a unit inpatient residential or day treatment program. However, if the addiction is very severe, you should probably treat the addiction first, because also diagnostically, you kind of got to figure out what's kind of going on with the patient. But if the addiction isn't too severe, the withdrawal is kind of better. You're pretty sure based on the history and kind of your complete assessment, they have ADHD and substance use disorder. You should probably treat both concurrently. Now, options can include day treatment if there's an absence of any severe medical or psychiatric comorbidities, if they have a stable psychosocial environment to go back to at home, if it's more recent onset of the addiction and it's not too severe and they're highly motivated. However, you really should consider residential treatment if concerned about any of those former criteria, which unfortunately is quite a lot of our patients. And so you should consider residential treatment if they have like any medical or significant psychiatric comorbidities, if their home environment is chaos, if it isn't recent onset, if it actually has been more than a couple years that they've been struggling with addiction, and especially if they failed treatment in the past as well, both inpatient or day treatment in the past, and if their motivation is kind of, kind of in the pre-contemplative, the contemplative range, then residential treatment is probably going to be much more beneficial for them. And that's something that we do at Edgewood Sandstone, as well as Edgewood in Nanaimo, both of which are considered really gold standard treatments in the private care system for inpatient residential treatment. Now, with ADHD and substance use disorder, they probably share a neurobiological similarity in terms of it comes down to kind of dopamine and what's going on there and dopamine regulation. So hence treatment of ADHD may actually then neurobiologically reduce cravings for substances. And like I showed you earlier, that's what they've actually shown in these pivotal studies. And early stimulant treatment actually has been shown to reduce or delay the onset of substance use disorders into adolescence and then into adulthood for these adolescents. So kind of the earlier, the better that you start, you can then actually usually have a much better prognosis in terms of addiction down the road. Now, there's a risk of diversion and addiction whenever, especially if you treat with stimulants. So like non-stimulants such as atomoxetine or guanfacine, they don't actually have abuse potential. And in fact, actually other ones that I could add to there would be dizipramine, which is a tricyclic antidepressant, Wellbutrin, which is a norepinephrine dopamine reuptake inhibitor. These are both antidepressants, as well as high-dose venlafaxine or Effexor. They've been shown to be effective and not addictive, such as the atomoxetine and guanfacine. However, they don't actually have as robust efficacy, though, as stimulants. So prescription stimulants have less abuse potential, I should add, too, than cocaine or methamphetamine, as they actually, have a slower disassociation from the receptors. They don't kind of get into the addiction network as kind of robustly as cocaine and methamphetamine in terms of activating kind of your neurons responsible for addiction. And also they kind of have like kind of slower binding and dissociation with other transporter proteins that are also responsible for that euphoric rush and hence the addiction. So first of all, prescription stimulants have much less abuse potential than cocaine or methamphetamine. So if you have somebody saying, well, you're just giving me one drug that's just as abused as these stimulants I'm taking, saying, no, their abuse potential is much less. There's still a potential for it, but that actually is more for the immediate release preparations. The long-acting stimulants have much less potential for injection or snorting, which is actually where you get kind of the addiction and euphoric kind of rush from them, than immediate release preparations. And a good kind of rule of thumb is which I tell a lot of my residents and students, is if you actually go to a 7-Eleven parking lot at night with a box of immediate release stimulants, you'll make a fair bit of money. If you go there with a box of, let's say, the long-acting stimulants such as Vyvanse or Concerta, you won't really make all that much money. People don't really want them. It doesn't cause them to feel high. It doesn't have much street value. Generally, patients with ADHD who have either conduct disorder or a history of substance use disorder, or both, they're at the highest risk for diversion and misuse of ADHD meds as well, right? And so if they kind of have conduct disorder historically with the ADHD and substance use disorder, for sure, you really have to kind of watch them in terms of their medications and never use an immediate release preparation really for any of these patients, I'll be honest. And so hence I only prescribe either the anamoxetine, or I don't really use guanfacine very often because it doesn't actually have that much evidence in adults, just case studies, but they didn't actually do randomized controls trials. But the long-acting stimulants for sure is what I primarily use. And I try to use the ones that have less abuse parameters, which I'll kind of go over with the list here. Now, it's not all about medications. There are psychosocial interventions that actually help build skills and help these patients a fair bit. So psychoeducation, empowering the patient and family with knowledge about their disorder. Certain behavioral interventions, such as kind of a reward or consequence, kind of especially more in children, but even in adults. Environmental management, so making sure that their workplace environment, you mitigate it for anything that could trigger a lot of their stress. Coaching them through helping them with more positive lifestyle changes. And because like fatigue and sleep is actually a huge part of that, making sure that you really work on sleep hygiene with a lot of them. Social interventions, so social skills training, anger management training, talking about leisure education and things, that also is very helpful. And of course, education and vocational accommodation. So in terms of academic remediation, writing a note for their university or college saying, yeah, could you please give them kind of a little bit more time in terms of tests or deadline support, and then even workplace interventions as well. And of course, psychotherapy is a huge key here. And cognitive behavioral therapy is some of the most robust evidence, but so does dialectical behavioral therapy, interpersonal therapy, family therapy, self-talk, supportive therapy. All that actually has been shown to help for outcomes as well. Now, this is actually from CADRA. So CADRA is our Canadian ADHD Resource Alliance that they publish actually a fantastic guideline, and they update it about every year almost, that actually goes over all the different ways to treat ADHD. And this actually goes over all the long-acting stimulants, which they actually say should be first line for anyone with adult ADHD, but also I want to add specifically also for patients with substance use disorder comorbidity. That would include Adderall XR, which is an amphetamine mixed salt, Vyvanse, which is actually a precursor of amphetamine, and so it doesn't even get activated to become like a dextroamphetamine molecule until it's actually been passed through, and so hence it doesn't actually have the addiction potential comparatively to most other long-acting stimulants or stimulants in general. So hence Vyvanse is one that I often use kind of first line, that or Concerta. And the reason why I like to use Concerta is with the nanotechnology in terms of the laser, not really nanotech, but what they did was they made like this osmotic semi-permeable membrane with kind of laser kind of holes. So it's really high tech and hence doesn't act, it's very slowly released and hence doesn't cause that euphoric rush. And so hence, and And that's also, by the way, only brand name Concerta. If you're actually prescribing Concerta and or generic Concerta or just writing Concerta, often pharmacists will actually substitute generic, which is actually just long-acting methylphenidate, which actually has a fair bit of addiction potential. So if you actually do prescribe Concerta, make sure in brackets you always write brand next to it, or if you ask a physician you work with to give it to one of your patients, make sure that they give the brand name because that's the one that has the less abuse potential. Foquest is a long-acting methylphenidate. In fact, that's the one that lasts the longest in theory. Now, all those hours that they actually say on the side there, actually, I take with a grain of salt because actually, generally, it's usually a couple hours less than that per. In fact, actually, probably about 3 to 4 hours less for some in terms of everybody's a bit different in terms of how they metabolize. But yeah, to be honest with you, if you use any of these medications on this list, in general, you're really benefiting your patient who has comorbid ADHD and substance use disorder. And these really should be your first line. The other one that you could consider as first line is Strattera or atomoxetine. This was in second line dosing schedule in CADRA, but when I'm looking at patients who have comorbid addiction, I would put it up to first line as well, because in theory, that has no addiction potential. The thing about Strattera is it's a norepinephrine reuptake inhibitor. All these other ones, in terms of methylphenidate or amphetamine based, they actually work directly on dopamine kind of propagation and stimulation through different ways. Atomoxetine or Strattera actually works more with norepinephrine reuptake and increases norepinephrine loads in kind of your brain. That's why, though, it takes longer to work, though. So all these other ones, and in terms of the long-acting stimulants, you'll notice benefit within the first even day. And actually, when they get a stable serum level by around day 5, that's when you kind of know even like, wow, this really changed them a lot. Strattera or atomoxetine does take arguably about 6 to 8 weeks to work. And in patients who are used to rapid kind of, response and ADHD, they may not necessarily then, you have to kind of let them know about that delay so they don't just kind of give up on that medication. It does work well. Doesn't have as many robust outcomes. I think stimulants are around the 80% mark almost. Strattera is around the 50 to 60%. Still works well if you actually look at the number needed to treat, et cetera. But really, frankly, the long-acting stimulants are usually my go-to first. Now, all these other ones on the list, such as the dexedrine, low, like kind of the immediate release ones or slower release ones or Ritalin, I don't use in patients with comorbid addiction because of the risk of diversion and the risk of reactivating kind of maybe a cross addiction. So I really do either Strattera or one of these 5. There are contraindications to stimulant use. Like not everybody can have them. If they have kind of, first of all, obviously, if they have a hypersensitivity or allergy to one of the products, you don't give it back to them. But if they have like kind of really high blood pressure, glaucoma, symptomatic cardiovascular disease, or they get often chest pain, pheochromocytoma or hyperthyroid, any recent treatment of an MAOI antidepressant, all those are contraindications. Now, the history of mania or psychosis is interesting. Now, if they're actively psychotic or manic, then yeah, in theory, yeah, don't give them a stimulant because you'll feel it with the dopamine. However, if they actually have stability in regards to their symptoms of mania or psychosis, you could then, in theory, consider, especially more for the bipolar, using a stimulant with the caveat, though, that's why I wrote the caveat there, that you put them on a mood stabilizer that makes sure that it doesn't flip them into mania. And actually, interestingly enough, antipsychotics have been shown not to actually be effective to stop that flip, but things such as like Epival or lithium, kind of more the anticonvulsant kind of meds, actually do prevent that risk of flipping them into mania. With psychosis, I'm just very careful. I don't generally try. I would then more use Strattera or atomoxetine. The other option you can have is actually modafinil, which is a non-stimulating stimulant that they use to treat narcolepsy. In fact, actually has been shown to help for negative symptoms in psychosis and doesn't cause them to actually have worsening positive symptoms. They're all kind of things you could try. Although it's not a strong contraindication, if they're pregnant or they're currently lactating, you use precaution and kind of talk to them about the pros and cons. And then with substance use disorders, like I was saying earlier, I wouldn't use the shorter immediate acting stimulants, but I would use Strattera or any of the longer acting ones, especially the Vyvanse or Concerta. This is a case study. The case study is not that actually person. This is actually a famous picture in popular media of a person pre-methamphetamine addiction and then kind of in the throes of methamphetamine addiction. So I was actually referred, 30-year-old Caucasian female from a shared care family doctor and psychiatrist duo in Edmonton to actually the public system inpatient residential concurrent disorder unit I work in Clare's home. On history, crystal methamphetamine use disorder, and depression. In terms of kind of a lot of these other things, she had, I'm just going to refer to my notes here, she had quite a convoluted history. So there was a forensic history. I think she was in jail for forgery. I think she, I think kind of forged checks or something, kind of in her early 20s. Significant methamphetamine use daily for the last 10 years with intermittent binge alcohol use disorder. Family history of what sounds like ADHD. In fact, in terms of her psychiatric history, she was diagnosed with ADHD as a child, but wasn't treated as the family kind of like, oh, I don't really want to use stimulants on my kid. Medical history was fairly benign, but she's had insomnia and hyperactivity since she was a child. And her academic history, like in essence, she was a high school dropout. And even to make it that far to grade 12, even she was ushered through most grades to a kind of a very positive social demeanor in a small town, but academically always did really poorly. In terms of her occupational history, she's been working with this one car dealership type firms where she was like taking pictures and kind of helping with their ads and things. But she would actually, when I asked her about the methamphetamine, she wouldn't use it on weekends to party or binge it for partying. She would use it daily before work to help her focus actually during her job. Relationship history, sure, I forgot to also add really chaotic kind of relationship history. Has some friends, but generally though her relationship history was kind of over the map. So here, she couldn't really tolerate group therapy. Every time she tried to do board work, she felt frustrated, left early. Lots of negative interactions with with peers, and on the addiction unit, seen as brash, loud, pushy by co-patients. Considering discharge, and I believe the case manager's like, yeah, good, please go. You're just so disruptive here. So, after I talked to her, especially, with kind of a very thorough interview and kind of found out, well, it kind of sounds ADHD-ish, did an adult self-report scale, which is available through the CADRA website as well for free. And after, and actually after getting a lot of that history I talked to you about in terms of all those risk factors, I started her on Vyvanse. About 10 milligrams was about 1 month after sobriety was achieved, and titrated her up by 10 milligram increments weekly till we got to about 50. I also added trazodone as a sleep aid, titrated up to 100. And then within about a week, client interactions, group work drastically changed. She completed the program, which is actually a pretty intense program here, and continues to be sober 1 year later. She, in fact, still returns to the center to give motivational presentations to current patients. It changed her significantly, and it was life-changing. And in fact, actually, I think I have some really nice reviews on like kind of rate your doctor or something. I'm pretty sure she's the one who has actually the nicest one in there. I kind of feeling that was her. She was very grateful. So really, in terms of a case study, when you do treat the ADHD effectively with a long-acting stimulant, you can change their lives, not only for their substance-related events and issues with their addiction and their ADHD, but actually a lot of research shows their quality of life goes up so much. All right. And this brings us to, I have about 5 kind of clinical pearls. And after that, I'm very happy to take questions for the last 10 minutes, or I'm happy to stay a little bit longer too. In terms of dosing, 8% of patients actually respond to subclinical doses of the meds. So if they actually have side effects at the first dose, don't be like, oh, they're histrionic or something. No, actually a lot of people, even the initial dose might be too much for them. So try to pick something that you can maybe even break, or if you can't break them, then the other thing that you could obviously try is trying a different medication, or you could actually even like kind of take their existing medication and putting it in some medium where you can then actually then decrease it to a half dose. So that's the first dosing algorithm is Even the lowest possible dose might be overwhelming for some patients. But on the flip side, though, to be honest, that's about 8% of patients. 30 to 40% of patients actually require even higher doses than what the Health Canada maximums are, right? And because they actually kind of need that level, especially if the receptors were primed with these very high levels of like cocaine or methamphetamine for years, they actually usually need higher doses than what Health Canada says is approved. And sometimes you just go over by another dose or two. Treating GERD is really important. So GERD is essentially stomach acid that then causes heartburn, is the colloquial kind of expression for that. In fact, actually, what that does is if you have like a lot of excessive stomach acid, sometimes you actually don't get the entirety of the long-acting stimulants being delivered, especially things like Adderall, where the second bead, which is kind of under the first bead in terms of delivery, is actually then affected by the stomach acid. So if they have actually a fair bit of heartburn and stomach acid, this can actually then decrease the efficacy of the meds you put them on. And so make sure you actually treat their stomach acid issues, either with a proton pump inhibitor or more safely now, I think they're recommending more like things like Zantac and ranitidine because PPIs might be associated with osteoporosis, I think, in the long run or something. So another clinical pearl, tell them do not have any fruit juice or pop in the morning or coffee because it's very acidic within about an hour of using their meds. The reason being is it can actually negatively affect absorption if you have a highly acidic environment, like I mentioned earlier. And so hence make sure that they don't actually take their pills in the morning with juice or coffee. And make sure you kind of separate. They can have it with water, that's fine, but nothing with ascorbic acid, which is essentially a preservative in most juices, right? And so, and let's tell them to have their coffee about an hour after their meds or an hour before. Now, this other one is actually an interesting one where, people are always asking, well, can I take my meds during the week and maybe not use it on the weekends and maybe not use my meds over summertime where I'm not working as much or something, or I'm a student, I have summers off. It's a controversial kind of thing, and then obviously you kind of manage it with each patient specifically, but there's actually a lot of risk I find when you look at the stats that they can kind of get into during those periods where they're not taking their vacation time. So in essence, serious injury risk goes up by 4 times if you're not treated. Risk of speeding tickets and speeding goes up by 3 times when you're not treated. Your substance abuse risk goes up to about 4 times in some studies if not treated. Your risk of unwanted pregnancy goes up 10 times if not treated. And your risk of entering the forensic system goes up by 7 times when not treated. When you treat them, interestingly enough, all those risks almost mitigate down to general population. And so what I actually usually tell them is I don't care what you do on the weekdays. I'm more scared on the weekends where you can get in more trouble, right? And so you kind of go over all those risks. And of course, they then kind of decide whether they want to continue the medications during time off of work or school. But if you kind of go over all these kind of things, and I didn't even go over the risk of trauma goes up too significantly, right? You do kind of maybe counsel, you may want to just kind of consider just taking it every day because also social interactions get much better too when they're on it compared to when they're not. Not to say that once you're on the med, you're on that med forever. About every year, you should actually have it reassessed by a physician or healthcare practitioner who can then kind of say, okay, like a glasses prescription, sometimes some years you need kind of more, some years you actually probably need a little less, possibly you can go off of it because sometimes you do get some neural rewiring. So about every year or so, you should reassess kind of the dosage and requirement of medication. Popular one, this might take me a bit, but I'll make sure I kind of finish this. We still have 10 minutes for questions. Is there evidence for all these alternative therapies? Dietary restriction, dietary supplements, chiropractic care, neurobiofeedback. A lot of these actually, except for chiropractic, in fact, actually, even in a chiropractic journal showed it didn't change outcomes. So except for chiropractic, though, all those other ones do have modest effect in studies. However, those are usually biased studies, usually done by companies who are interested in promoting those things. When they've done double-blind RCT studies of most of these things, in essence, it had very modest changes or no change in terms of their outcomes for control of ADHD and functioning. So symptom and functional. So the caveat is, yeah, if you want to try them, you can. It won't hurt. But do not turn to those things in lieu of more valid treatment algorithms such as medication and all those other things I had talked about earlier, and do this instead. And so that's really the final line there is, if you want to use these alternative therapies, great. If you have the financial wherewithal or ability, I should say, to be able to do it, great, because most of them are very expensive. But don't do it at the risk of then stopping all the other more evidence-based types of care that actually have much better outcomes in treatment. All right. And I ended on a quote by a philosopher, Lil Wayne. I tried to pay attention, but attention paid me. And so I'm happy to answer questions for the next 10 to 15 minutes. I don't mind running a little late if need be, as I see there's a lot of participants, and I'm assuming Jeremy will kind of go through the Q&A and kind of help me out here.
Yeah, thank you so much, Dr. Ayaz. And what an inspiring quote to end on. So I really appreciate that. Yeah, so we can get to some questions because, like you said, there's lots, which is great. Lots of questions, lots of participation. So
I'm just flipping through it. Do you mind if I see one that really jumps out at me?
Yeah, go ahead.
Yeah, so I get this asked too. Are there possible issues drinking caffeine or energy drinks while on meds? Yes. It really changes the amount of dopamine significantly, and hence it's a modifiable factor that I want them to eliminate. So I tell them 1 to 2 cups of coffee a day, totally fine, within the kind of societal average. More than that throws off everything too much. And then kind of in terms of dosing of the stimulants, and it's just such a variable that just so, that we can't control because, that changes with each day, the amount you take. So I usually say, please, if possible, limit it to just a stable amount every day and not more than that. That's a very popular question to get. Sorry, I just wanted to grab that one first.
Oh, of course. Yeah.
Okay.
Perfect. So we can go to, so is there a breakdown of other substances of abuse? I'm interested in the difference between control and folks who use stimulants.
Okay, so sorry, in terms of control, meaning like a control group in terms of what the rates are, or?
It just says I'm interested in the difference between controls and folks who use stimulants. So maybe, yeah, I would say.
Yeah, sure. So they, like I showed you, I think earlier in that Canadian study from 2012, they actually looked at primarily alcohol and cannabis as categories, which are much higher in those groups than others. But other drugs of abuse, a lot of those other drugs of abuse, you're correct, are stimulants, right? Because like they self-medicate with stimulants to a degree. And so hence they have much higher rates of stimulant use disorder as well.
Perfect, thank you.
Yeah.
So they're wanting to know more about a good diagnostic assessment or screener for ADHD coupled with addiction in adults.
So really that comes down to, there's no screen that I'm aware of that actually looks at both. So you kind of use separate screens to screen for ADHD, and that can be some things as simplistic as the ASRS, the Adult Self-Report Scale, and they give it to their spouses and parents if they're still around. Looking at old report cards, those kinds of things. But then also in terms of screening for mental health disorders, such as substance use disorder, there's the audit for alcohol, there's the DAS for drugs, right? Those are actually very common ones that are actually available freely, right? So the drug abuse screening tool and the audit, the alcohol use disorder inventory tool, right? Those are the ones that I would be using as first line kind of things. And then of course, a fairly thorough psychiatric kind of history.
Perfect, thank you. What would be some of the alternatives for cannabis for sleep? Lack of sleep causes.
Oh, good. That's a great question.
Yeah.
Right. And so, first of all, one option you have, of course, is if they've been using a fair bit of cannabis, is actually converting into nabilone, which is a prescription synthetic cannabinoid, but at least the dose is constant. You kind of know what they're getting, at least as maybe a stopgap measure, because it also mitigates the symptoms of cannabis withdrawal. And the other thing then you could do is clonidine actually has a fair bit of evidence to help for ADHD insomnia. Clonidine is an alpha agonist medication that essentially just slows your brain down, and it used to be utilized more as an antihypertensive, but they kind of realized it slows actually a lot of kind of over transmission kind of in your wakefulness center. And so it really helps actually these patients sleep much better. And so clonidine started 0.1 milligram low dose, right? At night, make sure you screen for blood pressure before and after dosage within about like 30 minutes of them taking the med. And then kind of, and then of course ask them about pre-syncope and a lot of fainting and those kind of questions on follow-up, right? But that's probably the one that actually has the best evidence to control sleep. And of course, then trazodone, which is a non-addictive sleep aid that's primarily serotonergic, Dayvigo as well. These are all other options you have.
Perfect, thank you.
Mm-hmm.
So an assessment for an adult ADHD with a certified healthcare professional is quite expensive. Are there more affordable options for clients who don't have the finances to pay out of pocket?
Public system, right? I mean, if they're in Canada, right? Obviously, it's a long wait in the public system in most provinces now, unfortunately. But most psychiatrists are skilled enough to be able to kind of differentiate and help with diagnosis there. And then it doesn't always have to be a psychiatrist. A lot of family physicians and nurse practitioners do have an interest in mental health, right? And so kind of referring to them as well is another option. But unfortunately, in Canada, I can only speak in Canada, that's where I'm based. The wait list in public system is high, depending on where you are.
For sure. And then we have a question too. So speaking about the Canadian system, how do you find a list of medical professionals who assess and treat ADHD in adults? And they're specifically asking about Alberta.
Oh, okay. So I believe Cadra might be able to kind of help you there in terms of it actually has a list of the private ADHD clinics, probably. I don't think it's on their main website, but I think if you kind of contact them, I do know that even within Calgary and Edmonton, so the rural areas I can't speak on because I don't think they have any specific specialists there. There actually are ADHD clinics, both for children as well as adults. They're private often, but they're in the public system. So often you don't have to pay to see the person. It's still covered by your health care if you have active health care, which you should. But there are actually ADHD clinics located both Edmonton and Calgary, mostly private psychiatrists. There's one in the public system in Calgary by Sarah Binder at the Foothills. But generally, though, the private ones would be like Dr. Hamid in Calgary and a few others.
Perfect. And then we have more so like personal question slash case study.
Oh, yeah.
I have a family member who was diagnosed with ADHD at age 41. They are now 43, who is a heavy marijuana smoker as well as a heavy drinker.
Okay.
Displayed behaviors that would be described as paranoid and delusional, and he is adamant that these behaviors are due to his ADHD. Can you clarify and or speak to whether or not there is a relationship between paranoid and delusional behaviors that are attributed to ADHD?
No, it's the cannabis. Right. So I, like right off the bat, no, the cannabis. Just to go on a quick side note, the THC percentage of natural organic cannabis that people have been using since probably about 3000 BC. Jeremy, you want to guess what it is? The THC percentage before crossbreeding and when people kind of began like kind of modifying it with
I don't even
genetic.
think I could give an educated, but I'll say 17.
3%.
Okay, yeah,
2 to 3%, right?
Yeah.
So it's 2 to 3%. But actually, Jeremy, the number you just brought up is actually more what the average is if you go to a distributor. In fact, actually, it's low 20s now.
Okay.
So really, we're dealing with something that is fairly robust in causing psychosis because in the past, it was actually fairly, I'm not going to say safe, but pretty safe relatively to what we're using now. The THC percentages now are actually very dangerous in terms of causing psychotic states. Now, don't get me wrong, ADHD, is psychosis or paranoid thoughts a symptom of ADHD? No. But sometimes if they're taking a lot of a stimulant, in theory it could, but it's going to be the cannabis most likely. Cannabis actually causes that psychotic state much more statistically than any other drugs of abuse, right? And there's a lot of kind of theory. It's actually literally a separate talk on this, Jeremy, which I obviously don't have time to do today, right? But Yeah, for your specific kind of patient or family member, sorry, I would probably tell them to lay off the cannabis or start using lower percentage THC cannabis as a start. And it's not the ADHD.
Okay, good to
Yeah,
know. Thank you. And then we have time for one final question.
sure.
So, is there a significant genetic hereditary factor for ADHD?
Yes, yes. And so, sorry, I should have mentioned that earlier. Yeah, so there's a huge, it's one of probably the most genetically linked psychiatric illnesses that we deal with. And so if you have one person that you're treating for ADHD, you should tell them to have their family members screen because dollars to donuts, one of them will likely have it as well.
Perfect. Yeah, I think that could be a webinar in itself too, right? It's like the link
Oh,
between those. So we'll just have
all these questions are great questions. All of these could be an entire webinar on their own. I'll be completely
absolutely.
honest.
And that's the issue with like an hour time slot is trying to get to everything. But just to echo what everybody's saying in the chat, thank you so much for the information, for the insight, for your perspective, and everything that has to do with adult ADHD and addiction. Dr. Ayaz, it's always a pleasure having you. So thank you again for being here today.
Yeah, you're welcome. Thanks for having me.
Of course. And for everyone that attended today, thank you so much for your attendance. We will be sending out a follow-up email that will include a copy of today's recording, as well as the slides Dr. Ayaz provided, as well as some additional resources with your CEU certificate. That will be sent out sometime mid to late next week. Until then, we'll see you soon. Take care.